Okay, I want to welcome everybody today. We're going to have a wonderful program with Sidney Collin and Erin McMullen, and they are going to be talking about balance issues, which I know is at the top of everybody's list of things to watch out for because we're all going to have balance issues at some point. Do you want to show the next slide, Ashley? Just real quick. Okay, so I love this quote. I don't do alcohol anymore. I get the same effects just standing up fast. You got it? We've all fallen over, lost our balance, standing up too fast. But so Sidney and Erin are going to talk to us about some ways that we can learn not to fall over. So let me tell you a little bit about Sidney. She is the inventor of NexStride and is the co-founder and CTO of Zero Devices. She started the company while studying biomedical engineering at Cal Poly. She has an academic research background in computational neuroscience, which means she's really smart, with a research paper published in the Journal of Clinical Neurophysiology. The Pacific Coast Business Times recognized Sidney in the 40 and 40 under 40 list, as well as their who's who in healthcare, insurance, and life science lineup. Erin McMullen is a board-certified neurologic physical therapist who's been practicing for 16 years. She has treated people with Parkinson's for over 8 years at Northwest Rehabilitation Associates in Salem, Oregon, with the goal to prevent falls and maintain independence as long as possible. Recently, she has become an assistant professor in a doctor of physical program at Western University of Health Sciences, where she plans to educate the next generation of physical therapists on the best care for patients with neurological disorders. So I want to welcome Erin and Sidney. I'm going to turn it over to them. If you have any questions, go ahead and put them in the chat. We're going to mute everybody. And Erin and Sidney, take it away. It's all yours.
Okay, well, thank you for that introduction, Sharon. And I'll just start off by saying I apologize for my voice. My daughter gave me her cold. So when you have a 3-year-old, you're almost always sick. But I'll go ahead and get my screen shared.
And just while Erin's doing that, just to give everybody a little bit of a run of show, Erin's going to go into a little bit of general details about, Parkinson's, balance associated with Parkinson's, some fall risks and what we can do about it. And then we'll switch over to my screen. I'll give a little bit more detailed information about freezing of gait and the product that I created to help with freezing of gait. And some more details on what we can do about that. And then we'll have all of the questions at the end. If you have any questions along the way, though, feel free to put them in the chat and we can try and answer them along the way if there's something that's relevant during that time, if that's okay with you, Erin.
Yes, absolutely.
Okay, I'll watch the chat while you're presenting.
Thank you so much. Okay, hopefully you can all see this. Just my view real quick. Sorry. Okay. Okay, so we are going to talk about balance in Parkinson's disease. Again, as Sharon mentioned, this is a hot topic. I know all of the patients I've treated with Parkinson's, fall prevention was top of the list, and it's the thing that can make or break independently living. So our goal is always to maintain balance and independence as long as possible. So we're going to talk about how to do that today. What I'm really planning to do with this discussion today is to give you a little underlying knowledge about Parkinson's disease, and then the physiology of balance, and then how to reduce your fall risk. And what I'm doing here, because Sharon says this group is savvy. They've been highly educated with Parkinson's and all. So I'm really pulling out the recommendations that were put out by our governing body, the American Physical Therapy Association, just in the past year and a half. So this is not new knowledge in general, but it's new in the terms of we're finally getting to the point of here are the recommendations for all the physical therapists across the nation that this is what we should be training our patients to be in order to reduce their risk of motor decline and falls. So that's what you guys are getting today, which is really exciting to hand that information off to you. And then also after talking with Sharon, that the discussion about, how do you fall? How do you really safely fall? So I added that into this discussion today too. All right, so the physiology of Parkinson's disease, and I'm going to assume that you have some base understanding of Parkinson's, but general speaking, it's a deterioration of the specific part of the brain called the substantia nigra. This is a part of our brain that produces dopamine. And I'm not sure if you guys have heard of dopamine, but this is one that it reinforces our behavior, which is, habitual things that we do every day. We get a dopamine hit every time we do something that we are reinforcing in our brain. So I get up, I brush my teeth, I get a dopamine hit. So the next time I do it, I'm going to get that dopamine again. It's going to make me feel good about what I did, and I'm going to feel accomplished. If you turn in, like when you're in school, you turn in your paper, you get a dopamine hit because you're doing something positive for yourself. And so your brain rewards us with that because we want to do it again. And then it also helps with movement and with memory. So those are the basic things that dopamine does for us. And it really will help to keep us mobile, keep us active throughout our lifespan. So these are some of the physical changes with Parkinson's. So again, if dopamine is important for movement, these are things that can happen because we have less dopamine available to utilize in our muscles. So we'll see slowing down. That's called bradykinesia. Akinesia is a lack of movement, so it's even more challenging to move, and that can be somewhat associated with the rigidity. Rigidity is where, our body just starts, it's just harder to move, and you might find that, that stooped posture, you can see that in the picture over here, that stooped posture can be part of that, where the flexibility of the spine changes and it reduces over time due to that reduction in dopamine. We'll also see a dyskinesia. So that's just a slowing of movement, and it's more challenge with like coordination and those things due to the parts of the brain that are affected. And then freezing of gait is a big one. Not everyone will have freezing of gait, but this is one that where the body just doesn't move. It can't move when you're telling it to move. So you might find this more commonly, say like at a threshold. So you're walking from one surface that say is carpet, and you're going to transition into a wood floor. So that freezing of gait can happen in doorways or transitions, getting on an elevator. All of those can be more challenging because your brain has to feed forward information to say, I'm walking to a new space, and so I need to change my pattern of walking a little bit. And that's where the breakdown in the connection happens. We also might see some changes in cognition and changes in sleep and emotional regulation. So this is, I just wanted to make sure you guys had a visual for the stages of Parkinson's. This is the Hone and Yar scale, is pretty much what everyone uses to stage Parkinson's. So you can see in stage one side of the body might be affected. So maybe a slight tremor in a left hand, or a little bit more difficulty moving the left leg. So that would be stage one. It can go all the way up to stage 5, which is really can't do much activity, unfortunately, and more likely to be wheelchair bound or bedridden. So needing dependent care and a really severe stage of the disease. What I wanted to draw you guys' attention to is that stage 3. This is one that we'll talk about a little bit in the next few slides. And so this is mild to moderate disease. It's going to be on both sides of the body. but you're still living independently, you're still capable of walking and moving yourself. So we'll think about stage 3 again in the future here. The biggest thing I want to do is make sure that we know that not everyone will present the same. These are typical presentations for Parkinson's, but some people may have fewer motor symptoms and more non-motor symptoms. So again, that sleep disruption, some cognitive changes. And you can see in that picture there that it can affect younger people, that young onset Parkinson's disease. And it can look different when we're on medication versus in our off time with our medication use. So you can't always assume that somebody does or doesn't have Parkinson's just because of those typical symptoms. So here we are seeing what is balance. Balance is a combination of sensory information being sent to the brain. So the eyes, the inner ear, and our sensory information from our feet, our ankles, our knees, all of that information is going to our brain, and it's telling our brain, okay, we need a little more assistance from our calf muscle, or we need to tuck our hips underneath us a little bit more. So that information is processed by the brain, and then that motor response, turning on that calf muscle, et cetera, is the output of that information. And sometimes this information can be blocked. So again, if we don't have as much dopamine available to us, then our balance may be more affected because we are able to turn on the muscles that we need to correct ourselves. We also may see a mismatch of the sensory information. So when we age, we also see a change in our visual input and the sensory information, say from our feet, that can also change. So if we have a change in our sensory information, that information is going to our brain and it's not completely accurate, that also will be another reason why our balance may not look as good as it had previously. And then finally, there is sometimes a mismatch of timing of muscle activation. So the sensory information may have gotten to the brain, and then the motor output from the brain may have gone to the muscle, but it went on too slow. So again, that bradykinesia, so that slow movement, if my muscles can't turn on exactly when I need them, that also can be a reason why we may see poorer balance. Here's a visual of what I was just talking about. So you can see in the brain there that basal ganglia, it's important in all of those loops that we have for the information going and being processed through the brain. So the basal ganglia is pretty integral to our movement, as I had mentioned earlier, and you can see that in the visual here. So our brain is receiving that sensory feedback from the eyes, the sensory system, and the inner ear. It's sending out a motor output, and it's that loop that keeps going around and around. So now the thing that we're all worried, I call this the F word in physical therapy. So falls and Parkinson's disease. Falls can become more prevalent in that stage 3. Again, if you think back to that Hone and Yar scale, stage 3 is the mild to moderate, living independently, but having some changes on both sides of the body. So it's associated with restrictions and changes in performance of daily activities, but again, still maintained. And this is our stage where we really want to hit prevention and really try to give as many tricks to keeping us from falling as much as possible in this stage. Here are some reasons that we can sometimes fall, besides the ones I've already kind of mentioned with the mismatch at times. The rigidity, if my body isn't able to move as quickly and isn't able to move maybe at all in the way that I need, like I need to turn my body to prevent a fall, and I don't have that mobility in my trunk, then that can reduce my response to my reaction time to the fall. Having a tremor. This is one that if I'm tremoring, that actually is putting more of it's challenging my balance already. So I have an unnatural movement that's happening. So then I have to have a stronger core to maintain my balance. And sometimes we see that is affected as well. So that tremor can cause extra movement, and that makes us have to change our balance continuously. Again, dyskinesia. So if I have difficulty moving my body, I may not be able to move in the way that I thought I was going to again, react. So if I'm falling, I'm reaching for something, or I'm taking a step out, and if I'm missing that table, or I'm not stepping as far out as I thought I was going to, then that can also cause a fall. Retropulsion, so that's the backwards falling. It's very common in Parkinson's disease. And so if I'm falling backwards, I have limited abilities to really catch myself with my arms, or I have to take a really big step to stop my balance. So if I have a tendency to fall backwards and I don't take a step to catch myself, my fall risk is really high. That freezing of gait. So again, if my feet stop and they won't move, but maybe my trunk and shoulders are moving, then I have a higher likelihood of falling, because that shifts my center of gravity, my balance point, too far forward. And again, slowing of movement, so that bradykinesia, that's where if that reaction time is so much slower than what I need to stop my fall, that can also cause a fall. And then incontinence seems like a strange one to have on here, but incontinence is one that if I have an urgency to get to the bathroom quickly, then my other things above here, so my freezing of gait, my dyskinesia, my bradykinesia, my tremor, all of those can be even more likely to cause me to fall, because I'm trying to hurry myself and rush. And then that's when we see a lot of people have a challenge with falling. So the biggest thing that both Sidney and I wanted to do today is really show you that it's not just this downward slide. There are things that research has shown that can help us prevent our falls. And that's what we really want to talk about today. And like I said, these are things that are coming from our physical therapy research. And again, these are recommendations for all physical therapists to integrate into our training. So obviously medications isn't something that physical therapists do, but if you use like a carbidopa, levodopa, those kind of things, you can see a reduction in your fall risk, because we're changing the signal pathway. Therapy, again, is going to be on there. External cueing devices, we'll talk about. Internal cueing devices or techniques, community exercise and deep brain stimulation are all techniques that we can tap into. And it's really mix and matching. So one thing may work for somebody, but it won't work for another, and vice versa. So it's really kind of playing with, I think Sharon mentioned the cocktail. This is another opportunity to find the cocktail that works for you, but you have to try it. I just wanted to make this really clear. I thought this was a really cool picture, an MRI of the brain. So when we are exercising, the brain lights up all of the areas that need to be integrated into coordination, balance, etc. Medication, on the other hand, it's opening channels, it's creating new pathways and helping to reduce the symptoms of the diagnosis. But it's just really cool to see side by side that the exercise is really getting the brain on fire. And that's what we want for you guys. Because again, the Parkinson's lives in our brain. It's where all the damage is being done. So we need to train the brain here. So with our exercise, we can see a change in neuroplasticity. This is a big word to say that the brain can still learn and change. And that happens throughout our lifetime. There's no stopping, that term, old dog learning new tricks. Yeah, still can, because our brain is still flexible even as we age. It can change our attention, our memory. It can reduce depression and anxiety. Again, we're getting those really happy chemicals, the serotonin, the dopamine, et cetera. Those are getting released when we exercise. So we're going to have less depression, less anxiety. We're going to feel good about ourselves. We're going to reduce risk of dementia, which is always a good thing. We're going to see an improvement in our blood flow and an improvement in our sleep. We're going to help to get the cycle back where it should, because exercise can help make us tired when we're supposed to be, and regulate that for us. So let's get straight into it, the aerobic training and physical therapy. So I put all these in PT terms because that's where the recommendations are, but I'm giving you a little bit more education so that if you are a little more savvy and you can monitor these things on your own, then you are going to be more successful doing these things at home too. I do always recommend before you start any exercise program that you check with your doctor and make sure that it's safe for you, because this is a general recommendation. It's not specific for each one of you. But we're looking for moderate to high intensity. And you guys were talking about the book that you might have the speaker coming in for. And it sounds like you guys already know about heart rate max, which is awesome. So there was a question about how long am I supposed to be in this range? So here's some education for you. So we're looking at that moderate intensity that they're saying is 60 to 75% of our heart rate maximum. And there's a calculation you can do to find out what your maximum is, because it does change for all of us, especially by age. And then high intensity is 75 to 85%. If you think about that kind of effort, you're thinking, I am not having a conversation with my friend when I'm working out. I cannot, I might be able to say yes, no, and that's about it. You are working really hard when you're doing high intensity. You should be sweating. And with most of the research that we found or we looked at, well, the most common was using a treadmill or cycling, whether that's somebody who likes to be outside and bicycle, or somebody who uses a recumbent or an upright stationary bicycle. So we're looking at 3 sessions per week for 30 to 40 minutes. So that sounds like maybe a lot for people, especially if you're just starting out. 30 to 40 minutes might be a little bit too much for you, especially at this intensity. So I recommend if you're just starting out, don't necessarily worry about being right at that heart rate max or that heart rate intensity right away, because you need to build your body up to it a little bit. And another thing that's great is that we found that if you break it up into, say, 10 minutes, 3 times a day or 4 times a day, it's actually doing similar to 30 minutes in a row. So again, if you're just starting to get back into exercise, try to take small bites. So just start with moving your body and you're already doing something that's great for yourself. So if you can get 3 10-minute blocks in, that is excellent. So give yourself a pat on the back if you get that. And so you can see that when they're training at this level, their physical decline was reduced. So normally with somebody who maybe isn't as active, they might see a more steady decline in their physical performance. So this is saying with somebody who was doing aerobic training at this intensity, they actually didn't decline as much and may have even improved because they're getting all the benefits of exercise. They also saw an improvement in endurance, functional balance, and especially this is related to daily living tasks. So, I spelled that wrong, sorry. So this is something that I like to really highlight because we are looking for independence. I'm not looking for you guys to be marathoners. I'm looking for you guys to stay living in your own home and being safe. So I love this. It's really exciting that 10 minutes a day, 3 times a day, you can make positive change in your life. And then it also does show, again, improvements for cognition, sleep, and depression. So resistance trainings, a lot of people can be kind of scared of strength training and using weights, but it really has shown so many positives. And I know that the muscle soreness that can be associated with resistance training can be another one that's like, oh, I don't like to hurt. But again, this is something where if we build up into it, then it can be really positive. The biggest things I want to just highlight here, 1 to 2 days a week for 30 to 60 minutes. So if we have 3 days a week of aerobic and then 1 to 2 days of strength testing or training, you can see you're going to have some really great changes. They are looking at a 1 repetition maximum, which I do recommend. Again, if you're new to strength training, either a personal trainer or who is aware of what they should be doing with someone with Parkinson's disease, or a physical therapist can get you on an exercise program and then let you continue on your own. But just having that education around it would be really important. The biggest thing here too is just that you need to continue to strength train. So if we stop strength training, the carryover effect, it does stop after a while, and we are going to see a reduction in our strength if we don't continue building it or maintaining it. And the biggest focus on this one is core strength, muscular endurance. So we're looking at the higher repetitions. You see 15 repetitions is in there, just above. That is going to be muscular endurance. That's going to really build the strength to keep you active the entire day. So standing up from a chair, every time you have to go to the bathroom, you need that muscular endurance to be able to do that over and over and over again. So that's what you want to focus on. And then force of movement. So we're looking for power, because power can change with the changes at the muscular level. So the more you train it, the better it's going to be. So I really highly recommend you guys look into getting onto a training program. I did want to say again, there was that question of how much do I do? So this is an infographic from the ACSM. So they are the American College of Sports Medicine, and they did one recommendation level 4 specifically for Parkinson's. So I wanted to make sure you guys saw that, and I'll send the link to Sharon to share with all of you. So you can see the recommendations for each of those. Balance training. This one, unfortunately, I actually was kind of sad to see that the home-based program on this did not show the same improvements as in clinic. So if you do have balance training or balance challenges, it is a recommendation that you do go to a physical therapist and work specifically on that to then hopefully get to a level that you can maintain at home. But the frequency is 2 to 3 times a week and 5 to 10 weeks. And I just am going to go back to here. There is also that second to last line. It says resistance training with a balance component is preferred when it's safe to do that. So the biggest thing here is that 2 to 3 times a week. So we've already had 2 to 3 times a week for aerobics, for balance training, 1 to 2 times for resistance training. So it seems like it's a lot. And that's why I wanted to point out that the resistance training, if we can pair it with our balance training, you're kind of killing 2 birds with 1 stone. More bang for your buck overall. So this is going to be most effective in reducing falls in the early stages. So we're thinking the Hone and Yar stages 1 through 3. Those are the most effective times to start building up. We want to get better at balance. We want to strengthen the muscles that need it. And so if you can hit it in those stages, you're going to have a better, hopefully better quality of life in the later stages, and maybe not see as much decline as the goal. And especially just pushing off any falls is going to keep you living independent longer. So this is just a huge one to hit. It can have a positive effect. Balance training can have a positive effect on step length and walking speed. They showed that training on a treadmill with a physical therapist shows extra benefit. But the number one thing is that specificity matters. So if I want to be better at balancing when I go, say, to the beach, I need to practice walking on uneven ground that's similar to the beach. So if you have something that's really hard for you, like making turns in tight corners and those kind of things, then you need to practice that actual skill. And then the final thing there is the technology. There is a strong evidence of support with use of tech on that. And again, that would look different in every clinic or different at home, but there's different type of technology that can help us do better with our balance. And just touching base on fear of falling. Fear of falling is very natural. I have fear of falling if I'm, standing at the top of a building. Those are kind of things that it's a protective mechanism that our brain has established to help keep us from falling off of high things and hurting ourselves. So this is natural, but there is a point when we get into a cycle where we had a fall and our fear of falling increases. Then we reduce our activity, like, oh, I didn't like that I fell going down the stairs, so I'm just not going to do stairs anymore. Well, then we see a weakness that happens because we didn't use those muscles anymore, and then that increases our risk of falling. So that's what the fall cycle is on that right side there. So we really need to make sure that we are touching base on how do we break this cycle? What can we do to change your ability? Whether it's again, check back on your medications, we start a training program, etc. That's what we need to do to help reduce the fear of falling, because fear of falling is a negative indicator for more falls. So it is going to be associated with more falls. And I did just want to point out that aquatic therapy, so being in the water, you can reduce your risk of falling, reduce your fear of falling, and improve your quality of life overall. So it just might give you more confidence and comfort. Aquatic therapy is not for everyone, but it is a good alternative if you have no other options, or if your fear of falling is so significant. So next was external cueing. So external cueing is defined as an external temporal or spatial stimuli, including rhythmic auditory stimuli, visual cues, verbal cues, or attentional cues. That's a lot. So external cueing is something outside of your body that is trying to time your movements. So that rhythmic auditory stimuli, it's a metronome that's trying to go at a specific beat. Your brain takes that information that's coming in through the sensory system, and it processes it different, and it gets a motor output in a different pathway. So we're going around maybe some of the blocks that we had to still get us to be able to move. I like to use this a lot with my patients in that stage 3 and even stage 4, trying to give them that cueing so that they can start moving themselves, especially tight turns. Those are ones that I really find the external cues are very effective, or coming up to the threshold, those kind of things. And it can also be a visual cue, so a laser light across the pathway. That can also be another cue to give your brain a goal for where you're stepping. It can be used to reduce severity of physical decline and that freezing of gait. Freezing of gait does respond very well to external cueing, and it was found to be superior to other modes of intervention to reduce our motor disease decline, so our motor decline, and to help us with, again, that walking. So getting our longer step lengths, those kind of things, and helping us step over something or turn more effectively. So all of those things are improved with it. They recommend cueing between 20 to 60 minutes, 2 to 5 times per week, and 3 to 8 weeks was what the research studies were showing. I know in clinic, what I use it most effectively is I'll have a patient practice what their challenge is. So we have one patient who, coming in from his car into the building, is very challenging. So I have him use his device, and so he turns on his metronome as he's approaching the building to try to keep that rhythm as he opens the door and walks in. Same for when he starts turning. He'll start walking, he'll turn on the metronome as he needs it to turn in that circle. So I do try to use it more specifically to the task that is challenging, and then take it away when we no longer need it because we're in a comfortable place that we're used to. So it just depends on the person with that, but the recommendations there are from the research.
And Erin, Sharon asked a question in the chat about music as a cue.
Yes.
You want to talk about that a little bit? I'm happy to share too.
Yes, that actually is one of the auditory stimuli that does really work as well. I have a patient, she has young onset Parkinson's, and that music is her life. So we get on the treadmill and she turns on her favorite music, and she can change her walking speed and her step length so effectively because she's, stepping to the beat of the music. So it acts similar to a metronome, but it's more enjoyable for a lot of people. So it's kind of personal preference on that, but they did show that music is a very positive external cue for people to enjoy. And I think it is part of that enjoyment factor that, you're just listening to music. So, and I do think that there's a little bit of, if I'm in a busy restaurant, having a metronome on may not be the same as having music on, but I just say, again, find what works for you and what makes you feel most confident, and that's what you should use. But yeah, good question, Sharon. Okay, the training on the treadmill, again, is just something that showed greater improvement. So if you can find a physical therapist who does have what we use in our clinic is a safety harness over a treadmill, and we can really challenge people in a safe environment. So it is what was found to be most effective, but it's not going to be the only thing. So don't feel like that's saying that you have to do this to get the gains. But they do show that the treadmill kind of acts as another external cue. So it adds another layer of, you're supposed to step at this speed. You have to go or you're going to fall off the treadmill. So it adds that extra layer of cueing. So again, starting early in the course of the disease is really recommended. And then again, the effects can dissipate when the cues are removed. That may be, again, depending on severity, somebody who only needs it temporarily, that's okay. They've already done the activity that they needed the cueing for, so we can remove it. But there might be other people who, every step is really challenging for them, so they need a more consistent cue. So again, this is where this won't be like recommendations are for everyone. It's that you need to find what works for your body and for your needs. So here are 2 devices. I'm going to again send these links to you, and Sidney will speak more on the NexStride to give you that. Just a brief overview of the U-Step. If you guys haven't heard of it, it's a walker that has multiple wheels on it. And it also can have a laser and a metronome on it. So it can provide that external cueing. The biggest challenge, it's very safe because it's very sturdy, but if you don't need that big of a walker, that's the challenge I find with it. And then a caregiver having to lift it in and out of the trunk is another common complaint that I hear about it. But it is out there and it's very popular for people with Parkinson's disease. Briefly, internal cueing, this is, again, it's very unique for the person, but what you're doing is you're creating something inside your body and your brain that helps you to do what that external cue does. So it's helping you to break out of that freezing cycle, or you're learning that, again, as I walk up to the threshold, I need to start counting my steps, or I'm frozen, I'm gonna punch my arm across my body in the air and not hitting anyone. And that's gonna just change the pathway enough, it's gonna break myself out of that freezing pattern to then continue walking. So I have patients that, again, they'll say from here to that table, I'm gonna get there in 12 steps. And so then they'll count their steps. It initiates their walking much faster, and it keeps their stride length much longer. So those are some of the internal cues that my patients have used successfully. But again, it's very independent or personalized. So you, again, find what works for you. This is another one that the research showed as a very positive for exercise, motivation, quality of life, etc. So community-based exercise is one that just really consistently showed positive returns. And you guys have probably, I assume, you've heard about the boxing, Tai Chi, Ai Chi, Pilates. Those are all group exercise, community-based exercise that have, again, been researched and shown to have a positive change in quality of life, help with the non-motor symptoms. So again, our depression, anxiety, sleep, all of those. The one thing that it doesn't have a really solid change in that they could research was balance, unfortunately, which is the one that we want the most, but it is going to be a positive change overall. And so if this is what your preferred form of exercise is, awesome. You guys are doing the right thing for yourself. And again, hopefully you're seeing those non-motor changes of, again, your quality of life improvements. But there was no one thing that anyone had to do in order to see the benefits. And deep brain stimulation is not, my main focus today. So what I did is I pulled this quote from the Michael J. Fox Foundation. So it is implanted in the brain, and it helps usually, especially with tremor, reduction in the amplitude of the tremor. I've seen people have really positive response to it. So this is something that if you are interested in it, I encourage you to find a physician who is more heavily educated in it to have that conversation, especially on, is this right for me? Finally, this is something that I provided as, again, I'll send links to Sharon for you all. These are just videos that I recommend you guys watch, that if you want to practice this with, again, a trained professional is my recommendation, then these are ways that you can fall safely and try not to get hurt, hopefully. So I'm going to put that caveat, please don't only do this with your physical therapist right now. But again, I'll send those links for those videos to Sharon to pass on to all of you. And here are my references. All right.
Okay, so we're running a little bit behind on time, so I'm gonna make my portion of the presentation really quick so that we have lots of time for Q&A. So I'm going to shorten it a little bit, but I'll go ahead and share my screen here. Okay, so, Erin covered a lot of different topics in balance, and freezing of gait was one portion of what she covered. And I have a bunch of slides on what freezing of gait is and why it happens, but Erin went over that kind of more generally in her section. So I'll just, if anybody has any more questions about freezing of gait, I'm a huge brain research nerd, and I have spent a lot of time looking at all of the research behind it. So happy to chat about it more. Generally, this is what it looks like. So this is somebody who's experiencing freezing. He's unable to move his legs. He's trying to be able to take the step. You can see his legs are trembling. No matter how hard he tries, he can't take that step. Can be very frustrating. There's a lot of different triggers for freezing of gait. Sometimes going through a doorway, walking into an elevator, changing terrain. So if you're going from like a carpet to a hardwood floor, that can be a trigger for freezing of gait. And this happens to people kind of along the spectrum, right? This is one side of the spectrum where Jack is completely unable to move his legs. I have another video I can show you after this of a man who is able to walk, but you see his legs are trembling a lot as he's trying to walk. He's taking lots of really small steps rather than those kind of long strides that we want to see. As you can imagine, this is incredibly frustrating, also a major cause of falls for people with Parkinson's disease. So as Erin mentioned in her presentation, we look at these external cues are one option for how we can help overcome this. And what happens is we can use these visual and auditory cues to activate the goal-oriented part of the brain. And that allows you to bypass the damaged part of the brain that's causing freezing of gait. That's the automatic part of the brain. So just by adding a goal, right, we activate the goal-oriented part of the brain rather than the automatic part of the brain, and that allows you to be able to restore mobility. So all I did was take the most effective visual and auditory cues from research and combine them into a simple portable device that we can attach onto any cane, walker, or walking pole. So the visual cue that we use is a green laser line projected onto the floor in front of you, and the auditory cue is a metronome. So all you do is you visualize yourself stepping over that green laser line or stepping to the beat of the metronome, and that change of intention changes the part of the brain that's being activated and allows you to be able to restore mobility. So here's a video of Jack. We put this onto his walker for the first time, and he's able to start walking with it. Here's another video of someone who's actually experiencing a freezing episode. He's unable to walk until he activates that green laser line, and he's able to start walking again. Get out of those freezing episodes. There are over 100 peer-reviewed articles that have been published showing the efficacy of these visual and auditory cues, most notably in Parkinson's, reducing falls by 40%, reducing the number of freezing episodes that you get by 43%, and reducing the duration of those freezing episodes by 69%. So really impactful numbers there in terms of what the visual and auditory cues can do. We have all sorts of data on kind of efficacy, but I'm gonna just breeze through those for now. We're selling in 7 countries right now. We're in over 100 clinics across the US. We're in over 1,000 homes. It is covered for veterans through the VA. However, it is not covered by insurance outside of the VA right now. We do have coverage from an organization called the Parkinson's Wellness Fund, so they can help cover the cost for anybody who needs financial assistance. But then other than that, it's either cash pay or we do have payment plans on our website as well. This is just a great story of this woman who had fallen 4 times the month before getting NexStride, and then she got NexStride and she hasn't fallen since, and it's been like 6 months. But I'm going to save the video for later so that we can get to Q&A. What's special about NexStride versus, as Erin mentioned, there is another product out there called the U-Step. Really the major difference between NexStride and the U-Step is that we can attach onto any cane, walker, or walking pole, and the U-Step is integrated into that one walker. That walker is a great solution for people who need that improved stability. but it's heavy and it can be hard for people to use outside of the home. Like for example, we have people that use NexStride. Like here's a picture of here's one of our customers, Walter, and he uses it like hiking on his walking poles, you know, so U-step wouldn't be a great solution for him. And then here's just a picture of it on walking poles, on a walker, on a cane, so you can see that it attaches onto anything and gives you those visual and auditory cues anywhere. And then quickly just on the price, it's $500. I do have a discount for people who are here with Twitchy Women, which is Twitchy 50. That'll give you $50 off. And then we have payment plans. We have a 30-day money back guarantee so people can try it, see if it works for them. And then we already talked about the Parkinson's Wellness Fund and the VA. So there's some options. If you have any questions about how to get it or if it's a good fit for you, feel free to give us a call. I have my email and my phone number here, but I can also put it in the chat. Okay, there's one other video I want to show you really quickly before I stop here, because this was one of our customers just made this video for us and I just think it's so cool. 1 second, I have to share my screen again. Okay, so this is another video of someone who experiences freezing of gait. So this is David. He has a YouTube channel. It's called Life with Parkinson's. So you can see this is another kind of video of what freezing of gait can look like. So it's like starting and stopping. You see the like legs trembling. You can see, you know, it's a high fall risk just by looking at him. And then in the next part of the video, you see him walking with the NexStride smoothly. He's taking big steps. He's not trembling. And so I just wanted to show, I think that's a really powerful before and after video. Okay, so I'll stop there. And if anybody has any questions for me and or Erin, we are available to answer any questions. And I see in the chat, Barbara said, I had an audio assessment which showed recurrent and uncompensated left peripheral vestibulopathy and otolith dysfunction. How might this affect balance? That might be a question for you, Erin.
Yeah, I actually direct message, but I can pass that on. So what Barbara was saying is that she had some changes in her inner ear. And again, our brain depends on visual, inner ear, and then our sensory input from our legs, especially. And so when we have changes in there, that vestibulopathy and then the otolith change, that can negatively affect us. So it changes the amount of information the brain is getting, especially on our position in space with our head, because this is all getting my inner ear, that vestibular system activated. So when this is challenged or changed or diminished, then we're going to have to compensate with our visual system or our proprioceptive system. So those are the two things that we would have to depend more heavily on. And this is where if we have something that's almost removed from the picture, then we have to start talking about, is the device appropriate, those kind of things, especially if there's any falls related. So
I want to, as a cardiologist, I want to address this real quickly. There's a lot of vestibular issues that will cause imbalance. It can be benign
paroxysmal positional vertigo.
Yeah, benign positional vertigo, which I've had several times, and it's not fun, and it is really hard to maintain your balance. At those times, you may want to have a walking stick or a cane or a walker because it's for your own safety. But, that is transient. It comes and goes. Yours may be more recurrent because, of what's going on in your ear, your inner ear, but the inner ear is essential for balance.
Mm-hmm, very much so. I think we also had a question. Oh, sorry. Was there someone else?
I was just speaking. I didn't put it in the chat. I'm just curious. I don't have freezing of gait so far, but I do notice that when I am walking, and I do use a cane, that I kind of get to a point where I slow down and stop and like regroup and start up again. I don't know if that's called freezing or not. it's like I can go fine for a distance and then I have to slow and literally stop. And I'm wondering whether this device on my cane might help me smooth out and also maybe prevent some, freezing in the future.
I'll take my side of it and then I'll hand off to Sydney. But it does sound like that we talked a little bit about the bradykinesia, that slowing of movement, but also translating into a freezing of gait. So it does sound like that. And without seeing you, I don't want to just say absolutely this is it. But the NexStride, one of the things with that is that external cueing helps keep consistency. And I can hand off to Sydney for more details.
Yeah, I would say that's exactly what I would say as well. I think that the metronome especially can help with pace and keeping your pace consistent. And then what the laser does is it helps with the stride length. It helps with taking those big steps rather than small, quick shuffling steps. And actually so there's two different ways that you can use the NexStride. There's kind of on-demand cueing and there's continuous cueing. So on-demand is you've frozen already, you're already stopped, and you want to get out of that freezing episode. So you turn on the device, you look at the cues, you step over the line, and you're able to get out of that freezing episode, and then you can turn it off and keep walking. The continuous cueing is to prevent freezing from coming on in the first place. And that's what that 43% reduction in freezing episodes, that was with continuous cueing. So that's if you're using the laser and the metronome, when you're on your walk already, it can prevent that freezing from coming on.
Right, thank you.
Thanks for the question.
Yeah.
We have a question from Kimmy. How do you find a PT that knows this stuff? I've had some not so good experiences. Is there a set of questions asked to get someone who understands balance?
Yeah, I'm sorry to hear you haven't had great experiences. The biggest thing I would look for is finding somebody with an NCS similar to what I have. So they're board certified in the neurological sciences. And so if you find someone that has that designation, then you're more likely to have somebody who's keeping up with the neurologic literature. Otherwise, if you find somebody who maybe isn't super familiar, but they're willing to go down the path with you and learn more, you can bring them or let them know about the American Physical Therapy Association's, it's called a CPG. It's helping to give guidance, clinical practice guidance to all of our physical therapists. So you could mention that to them that, oh, I saw someone speak about it and it sounds like your national group has some recommendations. Can you look into that for me? Or are you willing to? But looking for that NCS is number one and what I would recommend. And I can send find a provider link also to help you with finding somebody more specialized.
Erin, what do you think about like the PWR certification or the LSVT big certification? So are those helpful?
Yeah, if you find someone with an LSVT big or a PWR certification, they have definitely treated patients with Parkinson's disease. And those are certifications, those are just programs that are very specialized to treating people with Parkinson's because it is so special in how we treat it, that it just gives really straight ways to treat. I will say that personally, I haven't obtained either of those because there's just so much that we can do. And so I use pieces of those in my training. But yeah, if you find someone with those, then you're definitely on the right path.
We have one more question, but what I'm gonna do is I'm gonna go ahead and do my end of my wrap up right now, and then we can stay on afterwards to answer any more questions. I want to thank both of you, first of all. It was a wonderful presentation. And I think, the key things we learned is you've got to keep exercising. You have to work on your core exercises, number one, to maintain your balance. And if you're having problems with breathing and walk, find some way of external cueing to help you get through this freezing of gait, which will reduce your falls. And whether it's with the devices that they have, or whether it's a cane, listening to music, or it's walking to a metronome, whatever it may be, using some kind of external cueing to help you get through and to walk. I'm going to ask Ashlyn to put up my slides, and then we will continue after this. So in February, I've rescheduled both of our December speakers who had to had to back out for various reasons. So February 4th, we're going to have a presentation on Strive PD with Amanda Harris. Strive PD is a way of keeping track of your exercise, your medications, and a whole bunch of other things. February 18th, Trumbull Club with Karen Skipper. We're going to be singing. If you want to, if you enjoy singing, it's one of those great things you can do for Parkinson's. And I see I made another typo. March 3rd, 2024, not 2004. We will have Kristen Meldrum, who is the person who's the author of this book that you can't see it. The book that I talked about last week, Parkinson's, How to Reduce Symptoms Through Exercise. So she will be talking about a lot of things that are related to exercise and how it's going to help you. And then on March 17th, we will be having our 4th anniversary of Sunday Mornings with Twitchy Women. So watch for more details on that as we go along. Next slide. Okay, if you have not signed up for our blog, you can sign up for it at twitchywoman.com. And we have this, actually, you don't even need to worry about this, because if you are attending today for the first time, your name will be added to our email list unless you otherwise indicate it. Next slide. And if you want a wonderful coffee mug like I have, or some other goodies, you can click on the QR code in the bottom right corner, or go to twitchywoman.com. You can find our swag. And next slide. We just had a discussion about this in our singles group this morning for peer-to-peer mentoring program. If you're newly diagnosed and looking for someone to talk to, or if you want to help someone else, go to our peer support program for women. And it's a great program. We pair women one-on-one with someone who can help them through their diagnosis and learn to live with the disease. And next slide, I think it's our last one. Oh, we have 2 chat groups, one on Tuesday mornings. That's anything goes, whatever you want to talk about. And then on Sunday mornings, we have Twitchies with our partners. And that's been going, we usually meet at 8:30 in the morning on the Sundays, where we have a program at 10. It's at 8:30 Pacific time. And next slide. And then we have 3 Facebook groups. If you have we just added a Care Partners Facebook group. So if your care partner wants to be part of this, they can go on and ask to be admitted to the group. It's a private group. So, and I think that's it.